Thank you, and thank the organizers for the opportunity to present. We often use the analogy of bridges. We were big bridge metaphor people, and so I put the bridge there. But what's interesting about cardiac surgery in general is that cardiac surgeons have an inflated sense of self. There's a tremendous amount of ego in the room when you're with a cardiac surgeon, and we underutilize teaming. And so one of the things that is really, really, really important is when we see patients with shock, we think we can give a benefit to the patient more so than we probably can. And I think my cardiac surgical colleagues in the room know that preoperative shock is not really a good treatment. It's not well treated by cardiac surgery. And there have been multiple studies to show this. And this is ischemic insult with shock, and looking at the mortality is 1 out of 5. I think you can almost do anything randomly with a better mortality of 1 out of 5. And so are there things that we can do? Well, if you have a little time to think about it, whether you use the Euro score shown here for patients with just acute decompensated heart failure, right? Looking at the Euro score 2 and the definite morbidity and mortality, you can see that it escalates significantly when the Euro score is higher. And so doing things the same way is probably not the best way to do this. We know that shock is important, that patients with post-cardiotomy failure, most of the time when you talk to a colleague about a post-cardiotomy case you have, or probably most of the people in the room, like my colleague Jonathan Haft, who get a phone call from a surgeon on a Friday afternoon with a bad problem, you think to yourself, this story started preoperatively. This wasn't, oh, he was fine, and then all of a sudden, post-operatively, you can't come off bypass. I mean, come on. So we know that. And so I'll just tell you a case here that we used, that we did this a little differently. This is a 48-year-old gentleman. He works at the hospital. He's an anesthesia tech. And to say he was beloved would be an understatement. He's beloved, and somehow I got a referral for him. But he worked at the hospital. He's active. He, like the story goes, I have another patient waiting at home with the same story. He goes, he has shortness of breath. Somebody treats him for bronchitis, pneumonia, doesn't get any better. Then they get an x-ray and they go, oh, that heart's pretty big. And you can see the x-ray. And then, of course, he makes it to the hospital. And then you can see what his heart looks like there. His heart is very big. He's got some MR. And you can see his left ventricular dimension is approximately 5.5. So it's not 6.5. It's not horrible. But that's what it is, and that's where he is. Here's his coronary cath, and you can see this patient, but his ventricle doesn't move well, but he does have tight coronary disease. Interestingly, he did not have chest pain. He had shortness of breath. He's got approximate LAD. He's lucky that he didn't fibrillate, right, because he's very active, and the anesthesia team tend to be slave drivers. That's a joke. So he underwent a planned cabbage ×5, with a Lima radial, mitral valve repair, and a planned percutaneous central device, VAD device, 5.5, so Impella. And you can see that here's the echo shows his LV post-operatively is nicely decompressed. The important part of that echo showing decompression is that that's the key to not having problems, is having low filling pressures. And you can see his creatinine as well as his N-terminal proBNP. And with the Impella in, which stayed for several days, and then it was taken out, and he went home, and he comes back to see me about 3 weeks post-op, and you can see his cardiac dimension has gone down, and his echo is read as an EF of 40, but it's clearly improved, and his dimension has improved as well. And some of the cardiologists who are probably not here would say, well, medical therapy will do that too, but certainly not to this extent, and now he remains symptom-free. He's back at work and doing fairly well. Now, this gentleman's preoperative STS risk was about 5%, and so probably we would have been okay to do the case without it. We would have wound up on a lot of drugs, and maybe he would have had a much longer length of stay. This is not randomized or controlled, right? But it is an anecdote, and I'll show you some more, just some data about what we've been doing for prophylactic MCS. And you can see here data from one of my favorite cardiologists in Belgium named Jerome Bax, who's done a significant amount of work looking at remodeling based on left ventricular dimension. And you can see the ROC and the sensitivity specificity, and the number is probably about 65 millimeters. So I tell my friendly referring cardiac surgeons to me that if they have a ventricle that's greater than 65, we should talk about it, or at least we should look into whether they're decompensated or compensated to evaluate them for their potential for advanced therapies, because the 65 is really where the cutoff is, where you don't necessarily get remodeling. Now, most cardiac surgeons, especially male cardiac surgeons, not Amy, know the phrase that it's better to ask for forgiveness than it is for permission, right? And forgiveness when you admit something to really disaster in the ICU, as opposed to, hey, I got this really sick patient. This is our series, and we've had 6 people that we had planned bridge to cardiac surgery with 100% survival. And then we planned 5.5 post-high-risk surgery, and the outcome has been good, but it's not as much as it is if you have it in and it's a bridge. Now, these are patients in our center, right? These are patients that we managed and not patients that were sort of foisted on us, and every cardiac surgeon and intensivist in the room knows what it means to be foisted on a case. And then these are the all-comers surgeries, so that these are people who got sent to us with 5.5s or colleagues, et cetera, and there are 3 categories. If you put it in before with an average STS risk and an EF of 28%, the mortality was about 7%, and Impella support was 10 days, and in this case they had it on an average 4.5 days prior they had Impella. In the second group, 20 patients with an STS risk of 18 with an EF of 17, and these are patients who were put in intra-op in all cases, including outside physicians as well as our team, and the Impella support was less at 7, and then days to Impella was 0. And then the last group is post, where you have a disaster and you put the Impella in, the 5.5, and you can see that the mortality was 58%, and the support was 12 days, and average of 8 days from one latecomer. So it's always better to plan, stick to the plan, and not have to deal with forgiveness. We know that ECMO, as much as everyone in this room loves ECMO, we know that ECMO for cardiac surgery, when you look at post-cardiotomy failure, pre is better, again, prophylactically, put in the cath lab, post is bad, and that the survival is really a crapshoot, right? And we know that. So the most dangerous phrase, Grace Hopper, I encourage you to look her up. I don't have time to discuss. She was an amazing person who came up with so many things, a computer scientist, the phrase debug, and said, we've always done it this way. Well, there are other ways to do it, and what if the information is wrong? The Cleveland Clinic, my colleagues Ed Soltesz and Faisal, looking at a way to evaluate patients for potential therapies, so that if you have a low EF, you have a true bailout and you know what options are open. And in this, they propose the myocardial viability. They propose a functional assessment, decompensated versus compensated with optimization, and looking at hemodynamic parameters to determine who might need this and classifying your patients according to those and not deviating from the plan. And as we say in Florida, if the Cleveland Clinic says it's right, it must be right, right? So remember, ECMO after cardiac surgery, and everyone here who does ECMO every day knows it's a crapshoot, right? I mean, you get, depending on the age of the patient, how long they waited, the shock statement, the recovery. These patients, some of them do okay, some of them do blatantly and gloriously bad. And you can see from the Impella 5.5, looking at post-cardiotomy shock and so-called bridged CABG, that the survival rates are better, because for the most part, we're dealing with left ventricular problems. We don't wait till it's biventricular. And so we've considered this as a bridge to next therapy, and there are many applications of both left ventricular and cardiac stabilization before, as well as giving you the pause to figure out what's the appropriate operation. Is it CABG? Is it PCI? And what other options there are. And this is a very effective way of pausing and doing this. And my last slide, the Impella 5.5 in a lot of ways disrupted how we think about this. It's also challenged the validity of a lot of older data, because now we have a robust pump that can be easily discontinued without a return to the operating room. It's a pump that provides nearly full support and stabilizes in the perioperative period for high-risk patients who have a tendency to decompensate after the stress of cardiopulmonary bypass. We optimize the patients, we stabilize, and when we plan to do it, my partners and I say, now don't back out, because the worst thing is you'd back out, and then the next night or that night, you have to come back and put it in. And it's not as easy to do in that circumstance. And so I leave you that. And of course, I'm from Florida, and we're looking forward to September 21st with the launch of the Artemis. Hopefully, it'll really hit this time. Thank you very much.
Since Scott is have to be catching his plane, so is any questions from the floor? So you don't use IBP nowadays?
We have not used an IBP except if it's a heart transplant and the patient had one pre-op. but we will not put a balloon pump in. We go straight to unloading.
And you use 5.5 mainly. This is need a cut down.
Yeah, so actually we use it off of the aorta. We tunnel it above the suprasternal notch on the left side, and it comes out very, very easily, and it doesn't require a separate access. The Cleveland Clinic, Ed Soltesz talks about with doing axillary cut down and doing a prophylactic graft and tunneling it, even having access. We think that central is easier, it's easier to remove, and it's actually, we think it helps you decide, and I think all in all, it's easier. If you do an axillary cut down, most of the time we have to have the patient asleep to remove it if we're going through the same incision. But if you do a central aortic, you can have the patient awake under MAC and do a transthoracic echo, leave a chest tube in, and then usually it comes out very easily.
Any questions for Scott?
All right, thank you.
Okay, thank you.
Thank you, Roberto. So Scott was talking about avoidance of disasters, and this is going to be a talk about disasters here. Mechanical complications of MI. So just from an epidemiologic perspective, there's almost 1 million MIs in the United States each year. A fairly small number of them have these mechanical complications, but they're very important. We're going to talk about specifically 3 of them. There's post-infarct, ventricular septal defect or ventricular septal rupture. There's LV free wall rupture, and then there's papillary muscle rupture. So this was an interesting paper that was embedded within a prospective clinical trial of STEMI. And so these are all the patients that had STEMI. And you can see that less than 1% of these patients had mechanical complications. The mortality, if you didn't have a mechanical complication, was 4%. The mortality, if you did, was almost 60%. So a mechanical complication from MI is really a harbinger of death. So I told you mortality is around 60%. So basically the concept is that you have transmural necrosis. You get infiltration of these inflammatory cells with lytic enzymes that basically makes a hole in the heart. So let's go through some of these complications here. Post-infarct VSD. So the description of repair of these things is really credited back to Willard Daggett. This was whatever that is, many years ago. You'll see a few things. Number one is most of these VSDs occur early within the first 4 days. Sometimes they will occur late, but usually it happens within the first couple of days. Where the VSD occurs depends on which artery was infarcted. So if it's the LAD, it tends to be anterior in the apex, and if it's the RCA, then it tends to be posterior and in the base. There are more technical challenges with posterior repair than anterior repair, but we'll talk about the overall implications of these two things. The likelihood of shock from either of them is the same. So you can see the likelihood of shock is about 50-50, whether it's an anterior or an inferior VSD. That doesn't seem to make a difference. Looking at the STS national database, the occurrence of it is flat. So it's just a couple hundred cases per year, which represents like 0.1% of all cardiac surgery. So this is a fairly rare thing. And oh, by the way, it's a very difficult problem to fix, and it happens very, very rarely. And of course, it happens everywhere. And so no surgeon really ever becomes a master at fixing this problem because of its infrequency. If you look at certain predictors here, the occurrence of cardiogenic shock is about 50%. And you can see in this series, almost 2/3 of the patients had a balloon pump. So I do question the 50-50. They put a balloon pump in for a reason. Presumably there was some hemodynamic instability there. And then this is the operative mortality. It's flat and it's high, 40 to 50% operative mortality for VSD. The overall mortality is going to be a lot higher than this. This only includes people that went to the operating room. So a lot of those patients, we chose not to take them to the operating room. So the mortality of post-infarct VSD is in fact even higher. And this is looking at the timing of repair. That's the title that I was given, timing of repair. And if you repaired it early, your mortality was very high. If you repaired it late, then your mortality was much better. And you think, okay, well then just repair it later. But obviously there's selection bias. Some people are so sick that you just can't delay repair. So it really is separating out the people that have worse physiology. And of course their outcomes are worse. But it's a provocative question. Is there something we can do to make somebody go from this to this here? The clinical presentations of these patients, is shock, as I said, dyspnea, chest pain. They will have a harsh holosystolic murmur. The whole physiology is based on this high left to right shunt. So that means you have a low cardiac output. The blood's going to your lungs instead of going out the aorta. And then, of course, you start drowning. You have pulmonary edema and volume overload. So the diagnosis is made, obviously clinically you hear the murmur, but then also on echo. So this is a patient that we had. Let's see, this is going to play. I think I have to click the button. I don't know if you can play these videos, but anyways, thank you. So notice the ventricular function is actually pretty good, but obviously there's this giant hole in the base of the heart. So this is an RCA infarct. The rest of the ventricle is okay, but hole, and then you can see this very large left to right shunt here. Thank you. So the management of it is going to be, afterload reduction. So if possible, you give them afterload reducing medicines, but most of the time, the management is going to be with a balloon pump. You have to be very careful about inotropes, because if you put them on inotropes, you may just be pushing more blood into the lungs. So it's tempting to do, but usually it's counterproductive. So this is a paper looking at risk factors of mortality for this from a large series. This was out of, I believe, Montreal. VSD location. So any surgeon knows that it is much easier to fix the anterior VSDs than the inferior VSDs. And how do I go back? So it was a predictor by univariate analysis, but by multivariate analysis, it sort of fell out. The predictors were age and time between onset and repair. So again, a suggestion similarly to the other publication that delay is better. So the whole concept of repair is that you cut into the infarcted ventricle. It's already dead, so you can cut into it. And then you close the VSD with a patch, and then you close the ventriculotomy. This is the Daggett repair that was described, again, 40 years ago. So you incise into, this is an inferior VSD, you incise into the dead muscle, big giant patch here, and then a second big giant patch here. You can't close this because it's all infarcted, so you have to do something in a way that relieves the tension. Now, the alternative approach was proposed by Tyrone David, a single patch repair, an exclusion technique. So you just put one giant patch that excludes the VSD and excludes the ventriculotomy. I've done this once. I do find spatially it's a little more challenging to do. I've done this more times, and I've gotten out of the room, but survival is the same as everybody else's. So this is comparing the two different approaches, this particular study, obviously is affected by historical bias. It's also affected by the location bias. They had more anterior VSDs with the David repair than with the Daggett repair. The timing was actually early in these cases. I think this paper was out of Norway, and I don't know if there's something about their system, but they do tend to operate on these patients early. Very few of them were defined as shock, but their definition of shock was renal failure, which I thought was kind of a funny way to define it. But then obviously the era. So all the Daggetts were early experience and all the Davids were in the later experience. But the outcomes were clearly better with the David. Mortality was substantially reduced. But also note that of the survivors, a lot of them had residual shunts. So oftentimes you get out of the room, but they still have some degree of VSD. So you've made the intolerable tolerable. And then there's their Kaplan-Meier survivor curves. Here's another publication looking at percutaneous options for this. So instead of opening the patient up, can you put one of these Amplatz plugs in these things? And for the most part, it really is a bailout for the undesirable population. Mortality is super, super high. If you're in shock, most of these patients died. If you're not in shock, still a very large percentage of them died. It doesn't seem to be an advantage over traditional surgery. So I was asked to talk about the timing of it, and somebody already did. Basically, the bottom line is that if you can delay these patients, that's great. If you can't, well, then obviously you just have to move ahead. This was another publication that also specifically described the potential benefit of cardiogenic shock, hemodynamically unstable, using mechanical support, and then repair at a later date. And in fact, this is a publication that describes that using ECMO as a way of buying you time. Some of the concept of it is not only allowing stabilization of the patient, but maybe allowing a little bit more fibrotic tissue to accumulate in the infarcted area so that you've got a better surface for which to do your repair. I do question that because fibroblasts don't normally infiltrate into wounds until 4 to 5 weeks later. But nonetheless, this was the approach of this particular group. They put all these patients on ECMO. This is the time between the VSD and when they did definitive repair. And of the 4 patients that had surgery, 3 of them survived, so they felt it was an appropriate approach. So very quickly, I'm going to talk about free wall rupture of the left ventricle. So there's two different types of free wall rupture. There's the acute onset. They have a huge pericardial effusion. Often on echo, you'll see thrombus in there, suggesting that it's acute. Most of these people die, and in fact, most of these people die before they ever make it to the hospital. So it's really underestimated how often people have free wall rupture because we don't really know. What we know is mostly from autopsy studies. But then there's a different class of presentation, which is sort of subacute in onset. These patients tend to present with pseudoaneurysm formation. This is much more common in a reoperative setting. Somebody had previous cardiac surgery, their pericardium is stuck, and so that creates an enclosure for that pseudoaneurysm to gradually grow over time. This is exactly a case like that, a CT scan of a patient who had previous cardiac surgery. This is actually all pseudoaneurysm right here. This is the wall of the ventricle, and you can see a whole big part of it is missing right there. And then if you can play that echo, yep, there we go. So there's something missing right here. This is all pseudoaneurysm right here. And there you can see the mechanical, or the bioprosthetic mitral valve that he'd had about a decade before. This is a paper looking at this particular problem from a pathologic perspective. Basically, there's just a hole in the heart. And they describe it into three different categories. There's acute, subacute, and then the pseudoaneurysm, which tends to be the late formation. I kind of put these two sort of in the same category right here. The idea behind it is that repair is very, very difficult when you do operate on the acute version. So the muscle is infarcted and the pathways are serpiginous. And so when you try to repair these things, oftentimes it just leaks in all kinds of different places. So here's a group that said, we actually recommend when you repair these things, don't put any stitches in. Just put a patch and glue on there. And sometimes they sutured it, and many times they just put the glue on there directly and found the same survival as the rest of the group. So it's an interesting proposal, and it is something that we have done at our own program. Pseudoaneurysm repair is very different because that's late, and so it's fibrotic, and often it's more feasible to do a direct suture repair of that. Again, talking about the concept of delayed surgery and bridging with ECMO. This is interesting because this is a patient who presented with what they believe to be free wall rupture. The arrow is pointing to a hole in the heart. They presented in shock. They put him on ECMO. The patient clinically got better. They took him off ECMO. They sent him home. And then 3 months later, they got an MRI and the effusion's gone and everything was better. I don't recommend this strategy. It's sort of interesting, the concept, but I don't think it's going to work for all. And then lastly, I think I'm like way over time, papillary muscle rupture. So the idea is, again, you have necrosis of the papillary muscles. This is your mitral valve. These are the papillary muscles that hold the cords. And the degree the papillary muscles are particularly prone because they're very far away from the epicardial vessels. And how much MR you get depends on how much of your papillary muscle pops off. If it's just the tip of it, you may still have some cords. You may not have a lot of MR. But if the whole thing necroses, you're going to have a whole lot of MR. And it's important to recognize, we know people that have MR. In fact, I'm sure there's people in this room that have MR. If you have long-standing mitral regurgitation, your left atrium gradually dilates over time and becomes more compliant. Acute severe MR is very poorly tolerated because the left atrium is small. And so you suddenly have very high left atrial pressure and massive pulmonary edema. So this problem does need to be addressed with some degree of urgency, unlike chronic MR. The typical situation is a recent STEMI with progressive dyspnea, an audible murmur. The surface echocardiogram is usually pretty diagnostic. So here's the left ventricle, the mitral valve, and then you can see all this bulk here. That's the papillary muscle that's kind of, waving at you. And then, of course, the severe associated MR. You usually want to do a cath. Not only do you want to find the culprit vessel, but you want to see if the patient has other associated coronary disease. The management is optimization for organ perfusion, try to eliminate pulmonary edema, and then urgent surgical correction. Usually you replace these valves more than repairing the valves. These are not myxomatous mitral valves that give you a lot of opportunities for repair, but it is possible in certain cases. And so here's a paper where they did a repair. This is the actual papillary muscle there that's ruptured. You can see it's broken off right there. And then they did a complex repair, and then this is the nice result, the nice smile of a competent mitral valve. Anterior leaflet and posterior leaflet looks really good. It can be done, but most of the time these are replaced. Preoperative ECMO for this particular situation. This group had people that had high Euro scores, high STS scores, and the use of ECMO sort of downgraded those patients and made them better operative candidates, leading to better results. So in summary, mechanical complications of acute MI, these are rare, but they are very, very life-threatening. Surgical correction is really required for survival in any of these cases, except that one case. That there may be a role for percutaneous preoperative optimization, ECMO, and other forms of mechanical support. Oops. And I think that's it. Great. Thank you very much.
Thanks very much to the organizers for inviting me to speak on this topic. I apologize in advance because I'm the only non-cardiac surgeon in today's session. And I'm going to talk about entirely about veno-arterial ECMO for reasons that will become apparent in a second. I have one disclosure, which is I'm on the board of ELSO. So inherent in the title of this talk is, when is VA the answer? Well, I'm going to dismiss that immediately because I think you're talking about two different patient populations. The patient with septic shock in whom you put on VV ECMO is very different from the one that you would put on VA. And the reason for that is VV ECMO is usually a part of a multimodal strategy to address multi-organ failure in somebody who may have the technical definition of septic shock, but does not require mechanical circulatory support. And I quote the redoubtable Giles Peake, who says, if the indication for ECMO is hypoxic respiratory failure, it doesn't matter how many inotropes you're on, and it doesn't matter what the ventricle looks like, you should go on VV ECMO. So that group I'm going to dismiss and just focus on the group that do require mechanical circulatory support. Now, those of you who work in adult ICU may question why on earth would we ever want to use ECMO for septic shock, which is a very good question. And up until recently, most people would have dismissed it out of hand. If you work in a pediatric intensive care unit, though, you would be aware that there are a multiplicity of different hemodynamic manifestations of septic shock, and a lot of it is determined by age. So if you look after newborns with severe sepsis, the most common pattern, although by no means the exclusive one, is persistent pulmonary hypertension of the newborn and right heart failure. Sometimes as the child emerges out of infancy into the toddler age range, not necessarily the most common, but a very common manifestation of septic shock in that age group is so-called cold shock. So if you do an echo on these children, you will see a very, very poorly functioning systemic ventricle, child's cold shut down with poor capillary refill and progressive multi-organ failure. And the differential diagnosis for that is usually myocarditis, because they look very similar. But as we move into the adolescent age range, of course, distributive shock becomes the most common pattern by a huge majority, which is a kind of complex hemodynamic set of manifestations, which include tachycardia, dilation of the left ventricle, a reduction in ejection fraction, and an increase in cardiac output. So in that group who already have a high cardiac output, why would you use ECMO? And indeed, if you looked at available data up until recently, you would agree with yourself that it would be a total waste of time. So these are 3 observational case series, all from Asia, looking at the use of ECMO for distributive shock caused by infection. And as you can see, the overall outcomes were atrocious. There's less than 25% survival. If you look at the pre-cannulation physiology, nearly half of the patients in some of these series had already arrested. So you can imagine progressive septic shock, progressive multi-organ failure, everything else has failed, culminating in cardiac arrest, and then you put them on ECMO, you've probably missed the boat. So it's not really surprising that their outcomes are atrocious. But then, about a decade ago, we saw a case series from La Pitié-Salpêtrière Hospital in Paris, where they had nearly 75% survival. And this was comparable to what we were seeing in children at the time with the use of transthoracic cannulation, which I'm not going to dwell on too much. So Nicolas Bréchot's study from Paris showed that nearly 75% survival. So how did they do it? And the answer is patient selection. What they were seeing was patients who had presented with sepsis and distributive shock, but then, usually in young adults, a small proportion of them had evolved into that kind of toddler-like cold shock with progressive left ventricular failure. And when you look after these patients, you see obviously the catecholamines going up, the multi-organ failure worsening, the lactate goes up. And if you wait too long, then they start to develop malignant ventricular arrhythmias and they arrest. So obviously you want to get them on beforehand. Now, thankfully, this presentation is very rare. And even if you work in a center like Paris, you're not going to see it very often. So again, led by Nicolas Bréchot, we saw this study in The Lancet 2 years ago. So this is the best available evidence for this topic in adult medicine. So this was a study where they looked at the use of veno-arterial ECMO for cardiogenic shock caused by infection. So this, some people would call a septic cardiomyopathy. Now, the problem with the term septic cardiomyopathy is there is no consensus definition of what it is. So it's a little hard to compare studies if you can't even agree on the definition of a septic cardiomyopathy. I'll come back to the definition that they used in this study a little later. But the principle here was that all of these patients had sepsis-induced cardiogenic shock, and they were compared to about 130 patients from 3 large French intensive care databases. And there was a variety of statistical techniques, including propensity matching, et cetera, to try and align the patients who were on ECMO versus the controls. And despite the fact that the ECMO patients had worse multi-organ failure, they had higher inotrope doses and worse organ dysfunction, they had considerably higher survival, both adjusted and unadjusted survival. Now, by way of comparison, our group in Singapore had led this systematic review and meta-analysis for the use of ECMO and septic shock in children, which has been far better established than in adults, and demonstrated about 2/3 of these children would survive with the use of ECMO in published studies. So we then got together with Nicolas and Alain Combe and repeated a similar systematic review, but this time using IPD. So it's a meta-regression where you have individual patient data. So it's a more robust statistical technique. And we were able to show that the pooled survival was approximately 1/3 of patients in available studies. But very importantly, those patients who had worse left ventricular ejection fraction did better. So this is the paradox. The worse your ventricle, the better you did. And I think that's because ECMO obviously is not something that generally is used to support the peripheral circulation and vasoplegia. It's designed for short-term support of the failing ventricle. One thing that we haven't seen in adult medicine yet, but we have seen in children, and I think this is an important principle, is when we should apply ECMO, as in at what point should we say, right, this patient is going to do better with ECMO than not. Again, we don't have this in adults, but this was a study we did looking at about 5,000 children with sepsis in the Australia-New Zealand intensive care database, and 80 of those were put on veno-arterial ECMO for septic shock. And we were able to use a model that had previously been validated in other studies to look at the predicted risk of death. Now, the cutoff was at 47%, but let's call it 50% for convenience. So this slightly complex graph on the right merely demonstrates that if the child's predicted risk of death was less than 50%, and you put that child on ECMO, they did worse than if you hadn't put the child on ECMO. Whereas if the predicted risk of mortality was more than 50%, then they did better with ECMO. Now, obviously, that has obvious clinical limitations at the bedside, but I think the principle is important. ECMO is not something we should be using early in the treatment of septic shock. Nonetheless, obviously, you do not want to wait until they've had a full-blown cardiac arrest before you say, oh, maybe we should have thought about using ECMO. So on the left are what I would regard as conventional indications for the use of ECMO in pediatric septic shock. On the right are the inclusion criteria that Nicolas used in his Lancet study. So that was how they defined a septic cardiomyopathy. So you can see an inotrope score of 75, that's 0.4 of epi and 0.35 of norepi, for example, plus, and oral lactate of more than 4, and evidence of severe myocardial dysfunction. Now, I don't intend anybody to read this slide in detail. All it is to illustrate that there's a chapter in the new Red Book which goes through septic shock and ECMO for both adults and children. And this it's meant to highlight the importance of the cannulation strategy, as in when you might choose one over the other, what the risks and the benefits of them are. So this table is lifted straight out of that chapter. So I had the privilege of writing the editorial to accompany Nicolas' study, and whilst this is the last sentence, the last 2 sentences of the editorial, I think it applies to the topic as a whole, which is that ECMO is obviously a highly specialized intervention. As you all know, it's a low volume, high risk intervention. That this manifestation of septic shock, so advanced cardiogenic shock from infection, is very rare. You're not going to see it very often, if at all, but if you do, you should think that veno-arterial ECMO may be life-saving. Thank you very much.
Thank you, Dr. LaRusso. I do have the following disclosures. I speak for both Abbott and Medtronic, mostly about ECMO. If you aren't aware, in October of 2018, the heart allocation system in the United States changed to reflect the goal of trying to prioritize sicker patients to be able to receive a heart transplant sooner. Instead of waiting sometimes weeks to months, perhaps days, in many cities, they can now get a heart transplant. How it changed the allocation system, it went from 3 tiers. It used to be 1A, 1B, and 2. and now it's 1 through 6 are the statuses of the patients. Again, the goal was to get the critically ill patients who were dying waiting transplanted before that happened. Probably unintentionally, it did prioritize temporary mechanical support devices for patients over other support strategies such as inotropes or durable LVAD. In the past, most patients, when they were listed for heart transplant, were status 1B, and then as they progressed through their heart failure course, became a status 1A, and then were transplanted as a 1A. Right now, more than 60% of patients are listed as a status 4, 5, or 6, so in the less sick category, but at the time of transplant, nearly half are a status 2. So something has changed, and they've become much sicker by the time they get their transplant. We have seen some positive effects of the allocation change. The time on the wait list is shorter. However, patients are in the hospital longer before their transplant, and many more patients are inpatient in the hospital at the time of their transplant. And there's probably a lot of factors that go into that, but it may also be that patients are sicker at the time of evaluation now, and so they're staying in the hospital, having their evaluation, and then undergoing transplant. But we have seen also another good thing, that waitlist survival has improved. So fewer patients have died waiting for transplant. But then there were some challenges. The very first report of outcomes, of the 6-month outcomes after heart transplant with allocation change, showed only 78% survival at 6 months. Historically, that would be somewhere between 93 and 95% survival at 6 months. So it appeared to be a very scary drop in survival for patients after heart transplant. Also, we found that 40% of patients were transplanted with temporary mechanical support, so significant increase in that number of patients. Most commonly, it was an intra-aortic balloon pump used for MCS for transplant. But we did see that 8.6% of patients were transplanted from either VA ECMO or temporary BiVADs, which is about 10 times what that number used to be. In previous series of ECMO as bridge to heart transplant, the outcomes were bad. Some reported as much as a 50% mortality if a patient was transplanted from ECMO. We've also seen some effects on the donor hearts that we're using for transplant. The donor ischemic times have increased in every study. Some show about a half an hour increase in donor ischemic times, some up to an hour increase in donor ischemic times. And we do know that long-term has an effect on that heart function. There's also an increased distance traveled to obtain a heart. That is likely a large part of the longer ischemic time. We're traveling 150 miles longer to go get a heart. But that also significantly increases the investment in both time and the expense of traveling. So if you have to take a plane instead of an SUV, it's significantly more expensive to go get a heart for a patient. And we've also seen that patients that have a durable LVAD are being disadvantaged by this change in the allocation system. So these patients are waiting longer for heart transplant, and there's a lot of talk that the outcomes seem to be worse in patients that have an LVAD after their heart transplant. A lot of people presented this at ISHLT, and I'm still waiting to see the publications come out from what that data shows. But there is a lot of concern that for a multitude of reasons, patients are doing worse with LVAD bridge to transplant. And in fact, that has the consequence of a lot fewer LVADs being done right now in the United States. Most of the patients that get transplanted from an LVAD are status 4, meaning they've gone through status 1, 2, and 3, and the heart was not found to be acceptable for those sicker patients. And then it's used in a patient that's not as sick. And that may be the cause of some of those worse outcomes. And it may be in addition to the travel time, the ischemic times, or LVAD patients in general have always done slightly worse after transplant. Some maybe because of sensitization as well from their previous operations. It's a bigger operation to do an LVAD explant heart transplant. And this is a survival graph. This is after 1,300 heart transplants, so about a year, a little over, not quite a year, sorry, after. We still don't have a lot of data because we're only 2.5 years of data that we have right now for survival after heart transplant with the allocation change, because it takes about a year to get that first set of data. And you can see the red line is the new data for outcomes, and there is a persistent worse survival for patients in the new allocation versus the old. And it is an absolute 4.6% decrease in survival that we're seeing for patients after heart transplant now compared to before the allocation change. They've also shown some increased complications, so an increased rate of dialysis and an increased risk of stroke after the heart transplant. So what does the future hold for heart transplant, and how is MCS going to be involved in that? It is important that even if you have a patient that's really sick, they're on ECMO, we got to get them transplanted, continue to do that appropriate evaluation for that patient. Don't go and transplant someone and then find their colon cancer, their lung cancer, their large stroke after you've done their transplant. Make sure you do the right evaluation for the patient before surgery, because those patients are already at a disadvantage for a good outcome. So do everything you can to ensure a good outcome for that patient. If you're considering MCS for a patient in their course, of course, picking the correct device at the right time in their hospital course to minimize the complications. So if a patient can be supported with a lesser device, if you do it a little earlier, maybe that's the right course for that patient. And of course, always the focus on preventing device-related complications, so vascular injuries, bleeding, device infections, need for exchanges, avoiding those complications as much as possible. And then also, if we have patients in the hospital for longer, they're at risk for those hospital-acquired complications. They can get central line infections, they can get debility just from being in an ICU bed and not moving around, malnutrition. So make sure to focus on keeping the whole patient as healthy as possible to get them through their transplant safely. So all of these will be important going forward, and hopefully we can reverse this decrease in survival that we're seeing after heart transplant, but continue to bridge patients with devices to heart transplant. Thank you.
Open the session to a question from the floor. Please identify yourself.
Carl Moody from Little Rock, Arkansas, cardiac surgeon. I have two questions. One is for Dr. Haft regarding the mechanical complications of MI. Do you feel like with such high mortality for traditional repair, temporary mechanical circulatory support / durable, if appropriate, should be mandated for those repairs? That's my first question. And second question is to Dr. Haft and Dr. Hackman, Amy Hackman together. Would appropriate patients be considered immediately after massive mechanical complication after MI for transplantation and should be listed?
So your question about the mechanical complications, so post-infarct VSD, free wall rupture, and so forth. And I think the decision about when to use mechanical support depends upon the stability of the patient. There are some people who have restrictive VSDs and are quasi-stable and can be managed with a balloon pump and afterload reduction and go to the operating room under more controlled circumstances. But there are some that are in fulminant shock. And we used to take them to the operating room right away. And I think that's the category of patient that I think benefits from temporary mechanical support. I showed you the picture of the post-infarct VSD, normal ventricular function, but obviously a big inferior infarct and the VSD. That's not a heart you want to transplant. I mean, that person with repair should live a pretty good life and shouldn't need a transplant. But then, of course, you have a big anterior MI and cardiogenic shock. Is that somebody you think would be better off, going for transplant? And we've done it. But it's a more difficult patient to get through transplant. And transplant, it's a scarce resource. You have a commitment to the other people on your list. You have a commitment to the donors, the donor families that you never meet, an obligation to ensure the choices are made in the best interest of, using that organ, that gift for joy. So we do it, but I don't feel very good about it. We do it because we can now. We couldn't in 2017, but now we do it because we can. So Amy, what do you guys do?
I've done a little of everything. I've had some where we fix the VSD, they stay on ECMO, they're not able to come off ECMO and done a VAD. That's one option, to then make them hopefully a better transplant candidate if they need it, if they don't recover after a more prolonged period of time on a VAD. They are just sick patients, so using the temporary support sometimes for a long time to make sure you get the liver better, the kidneys are better, the lungs are better, and use the support to get them through that operation. It's still an operation that, those of us that have, I'm sure all had one that didn't do well, and it's very memorable to us, and wish we had a better option than something as drastic as transplant for that patient. I haven't done that. Have you done that?
Well, yeah, we've used total artificial hearts in these circumstances, but I think in the current era, it probably is not necessary. You can get these patients to transplant with other modalities.
Thanks. Great talks by everybody. My question to my friends and my colleagues, Dr. Haft and Hackman, if a patient's at your hospital waiting for transplant, is that patient on a axillary balloon pump or a femoral balloon pump? And let's say you are 3 weeks into it, is there a time limit mark in which you say, okay, we're going to go on to an Impella 5.5 because that person it's isolated LV failure and now is the time to move on, or you just wait?
I'll go first. I've had pretty much a hate-hate relationship with the axillary balloon pump. There's people with bad femoral vessels. You think, oh, I want to get them up and move them around. But I've seen so many problems with if the patient moves their arm, then the balloon pump doesn't work, with having to exchange them because they just don't seem to be working as well, with bleeding from around the balloon pump or when it's removed, bleeding. So I don't really love the axillary balloon pump. If they are on a femoral balloon pump and you're getting to where you can't keep them in bed any longer, that's when typically I'd go for an axillary Impella at that point.
I think the way we approach these patients depends on the circumstances of the patient. So the new allocation system was designed for altruistic reasons, and it was to help the people on the waiting list that were dying and had very few other options other than transplant. And it has morphed into a very different thing, that we are using axillary balloon pumps and femoral balloon pumps and Impellas in people that would be excellent candidates for an LVAD. But because we have a pathway to get them an expedited transplant, we are taking that pathway. So when we have a patient who's on temporary support, a balloon or whatever, and weeks have gone by, we would put a VAD in them if we think they're a good VAD candidate. Now, there are people who are not because of, recurring malignant arrhythmias, because of biventricular failure, the hypertrophs, and those are people that you just slog it out and you wait until you get your transplant. You keep your bait in the water and you hope you get a bite. As far as axillary versus femoral, just like Amy, we like axillary until we don't like it. And it can be a bit of a nuisance, but it is nice to walk the patients if it works. So I think you should try. Wait, it was you that told me to use axillary balloons, right?
I told you to pull it and hold pressure real tight.
Yeah, it didn't work. Yeah, I think axillary balloon's a very reasonable thing.
And which patient in your program goes on prophylactic ECMO, if anybody?
Prophylactic for
biventricular failure, both ventricles are not working. You have an option of either balloon pump or ECMO. It's not that far gone that the pH is down and the lactate's 8, as one of the previous presenters said.
And prophylactic, what do you mean prophylactic? Like
that means the
before
patient,
they clank?
You know that the patient has biventricular failure, creatinine's now 2.5, may turn out with balloon pump, may not turn out well with balloon pump. Definitely not an Impella candidate because it's biventricular failure. You have a choice of either balloon pump, try it, sleep at night, wake up, decide about ECMO, or no, the ECMO is the right thing to do.
I mean, I think we always try for left-sided support, and we wait until it doesn't work, and then we would escalate. But we usually will put a balloon or a tandem heart to provide left-sided support, and then if it doesn't work, escalate to something else. I think that's what we always try. Because if they do well with a balloon or a tandem, they're going to do very well with LVAD.
I would like to make a comment about that, sorry, because it's a very important point about prophylactic use of MCS. I made an internal evaluation of a patient who went bad after cardiac surgery in my unit. 90% of the patients who crashed and who received ECMO or whatever after surgery in the ICU, 90% you could predict it preoperatively. This means that it was a bad planning. The same mistake was really underestimating the risk of crash after surgery. So this means that with a good planning, with a prophylactic use of MCS, you could avoid a crash. And I tell you, I'm using more and more prophylactic ECMO or MCS in these patients because, you go in the OR with lactates of 0, 1.1, 1.5 to support, and then you stay on support 24, 48 hours, which is different. The patient will not get into crash and then support it and maybe 1 week of support to get rid of the crash. So I think really it's so important to make a good planning because 90% of the crash could be predicted before. I would like to make, a question to Graham. So, central of peripheral? Please, give us an enlightenment.
So just briefly, for those of you who don't look after children, there is a strong signal in the literature that outcomes are better with central cannulation. And that's probably because if you look at an infant and look at the caliber of their vessels in refractory shock and the caliber of the ECMO cannulas you're going to get in, if you put them on ECMO, you provide partial cardiopulmonary bypass, but they're in advanced shock and it takes ages to get them out of advanced shock. In central cannulation, using massive central cannulas, you can reverse that shock in a few hours. And they're often off catecholamines and on vasodilators like SNP within hours of going on central ECMO. Would I do that in adults? Well, I have done it in adults under very exceptional circumstances, usually incredibly late referrals with patients who are about to arrest or who have arrested. But I think, as with everything, you need to individualize your cannulation strategy. I think as a reasonable default, femoral veno-arterial ECMO is with a distal perfusion cannula is perfectly reasonable approach in adults because it's fast. It'll buy you stabilization, and then you can reassess. And if it's causing problems that you can't easily address, in particular differential hypoxemia, because they often have concomitant ARDS, then you can think about changing from femoral arterial cannulation to axillary cannulation. If you have time, I think the ideal strategy would be a jugular venous drainage cannula, an axillary arterial cannula, with or without a second venous cannula in the femoral, where you can either use VVA to get high flow, or you can use VAV to address differential hypoxemia. But that would be my approach.
Got one question for you, because I was hoping to hear about, you were mentioned that doing the post-infarct VSD right away, it come up with a high mortality, so we'd rather wait. But when you wait, then some patient will die along the way. So the question is, if you use an ECMO, so we can stabilize them for maybe 7 days, 10 days, and then go for surgery, would that be better?
Yeah, I do. I think if your patient is fulminant shock, is defined by transaminases in the thousands, lactates that's elevated, lungs that are white, you take that patient to the operating room and you know exactly what you're going to get. So I think under those circumstances, stabilization of the patient, allowing resolution of end organ function is the right approach. What I've seen in the literature is people describing delay to allow the VSD to fibrose. But it's not going to fibrose. It's not going to fibrose in 3 days or 5 days. It's going to fibrose in 6 weeks, and you're not going to wait on ECMO for 6 weeks, I don't think. And so I do think stabilization of the super shocky patient is the right strategy if the patient is really that ill.
But then how long would you wait?
Definitely until Thursday.
Okay.
Can I add one more thing to that? Have you used Impella in post-infarct VSD? Some people describe it.
Yeah, no, I don't have experience with that.
Question for Dr. Hackman, Dr. Haft. So to your point about the new transplant allocation system, and as cardiac intensivists, should we expect this to be a long-term trend that we're going to see more temporary MCS to get people on the transplant list, or do you feel in your world that people are seeing the signal of, hey, now people aren't putting in durable LVADs, or just doing temporary MCS to kind of game the system? Do you feel like in your world that that's going to change again, that the allocation might change again, maybe back to what it was?
I think it's unlikely they would change the allocation system again. For instance, the lung allocation system, last time it changed was 2008. So it's not something they do often. They can kind of change the rules potentially. So for instance, there's ways to get exceptions. So say you have a patient that doesn't quite meet one criteria or another, you can apply to a board and say, I think they should be listed higher than they are. And that has increased a lot with this new allocation change. So potentially if they change the exception rules, that may change how people do things. If they stop granting exceptions, for instance, it may transition people back to durable LVADs. But I think the decrease in LVAD implant for now for patients that are potentially transplantable has been pretty persistent, for the time that we've had the allocation change.
I think Amy is exactly right. I don't see a change in the allocation system in the near term, but what is going to change is behavior. So we've already changed our behavior to try to accelerate transplant using the status 2 criteria, which is short-term mechanical support. But as our transplant outcomes start to get worse because these patients are sitting around for weeks and weeks and developing complications, people are going to change. Transplant outcomes are precious. I mean, we do it for a moral reason, but we also do it because our payers and our regulators are looking at our outcomes. And if your one-year survival starts really dipping below 85%, you're in big trouble. You're going to lose your accreditation. So I do think programs' behavior is going to start to change.
I would like to just give you a very, very small suggestion. If you have your younger colleagues and you want to teach them to, think and make some good decision, I mean, the mechanical complication and MCS is a perfect way to teach pathophysiology. Because I always ask a young colleague, okay, you have a VSD, the patient is crashing, then you go on ECMO. Yeah, of course, you stabilize. Then the patient is crashing on ECMO. Why? Yeah, because you can increase the shunt. And then you put maybe, and then you say, okay, you have to reduce. Then you put maybe an impeller. And then the patient improves and then becomes again crashing and crashing. Why? Pathophysiology, I mean, you need to, the impeller then can invert the shunt, and instead from left to right, right to left. So I really like the mechanical complication and MCS because you have to be thinking what is going to change in your pathophysiology and the hemodynamics about the combination of devices. So you have to think and be careful because you can even make a worse condition to the patient. So I have a question actually to Jonathan regarding, so the issue about the European guidelines, they say you should wait for 7 days. But the guidelines from US, they say actually to go to the OR as soon as possible. So how can we manage?
Yeah, I mean, these guidelines are often, they take years in evolution. So I do think that those guidelines would likely change depending on the circumstances of the patient. If you had a patient that was relatively stable with a restrictive VSD, I think it's a good idea. We had, I think the echo that I showed of the pseudoaneurysm. That patient presented with dyspnea, and the cardiologist said, "Oh, this patient needs to go now." And we said, well, the patient actually looks pretty good. And I waited a month, and I let that thing fibrose because I knew it would be a much easier repair. So I think if the patient is letting you delay, I think it's in the best interest of the patient. The patient's in shock. You need mechanical support. I agree for resuscitation. But then the question you asked was, when do you do it? And you do it when it's right. You do when the patient has normalized their physiology, when their liver function is better, their lungs look clear, neurologic status is confirmed to be intact, and then I would take him to the operating room.
And then another question to you is, okay, we have bad patient, you do a repair of a mechanical complication. Would you do then a prophylactic support in bad patient because you can expect some deterioration afterwards?
In the experience that I've had, where you're on ECMO for VSD, you go to the operating room, you do repair, you come off on ECMO. You leave them on ECMO for a few days, let the dust settle. The idea also is to reduce that LV pressure for a little bit so you don't load that infarcted muscle that you've just reconstructed, and buy you a little time.
And Graham, two pumps, 2 ECMOs in the same patient?
Yeah, well described. I've never met the patient that I feel needed that, but I know some centers have done it, but no, not for me, thanks.
Okay, I think we have at the end of the session. I hope you enjoyed the presentation. I think the speakers were really outstanding. So thanks for joining us today at this session. And I really suggest you to keep on staying here. Another very, very interesting session is going to be in the same room. So thank you again.